long as I can get.
Well, after our brief summer hiatus, welcome back to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and please remember to fill out the program evaluations that you picked up on the way in. Give us any ideas you might have in regards to future topics or future speakers. Today, it is my pleasure to introduce Dr. Jonathan Burns. Dr. Burns is a fellow of the American College of Emergency Physicians and the American Academy of Emergency Medicine, and a member of the Departments of Emergency Medicine at McFarland and Mary Greeley, and he has kindly accepted our invitation today to update us on the resuscitation of life-threatening overdoses. And please join me in welcoming Dr. Jonathan Burns.
Thanks, Steve. It's been a while since I've done one of these grand rounds, and I forget. Let's get a kink in the neck by the end, looking straight up. Can everybody hear me okay? So. I just came off a night shift, so my caffeine levels are dropping dangerously low. So if I fall asleep before you do, please throw something at me. So I was asked today to talk a little bit about overdoses and toxicology. I'd done a series like this a few years ago, and as I talked and asked around a little bit, I was initially going to do this just on some rapid-fire antidotes, and we'll touch on some of that stuff at the end, but as I talked and asked a little bit about what the medical staff was most interested in, one of the big things that I kept getting more and more of was, what do we do with this new opioid crisis? How do we treat these new synthetic opioids and these fentanyl, diluents, and heroin, and all that other stuff? So we'll talk a little bit about that for sure. Somebody asked about acetaminophen. We've had couple of bad acetaminophen overdoses lately, and we've had two bad ethylene glycol or antifreeze toxic overdoses lately. So I was asked to touch a little bit on the higher alcohols and the volatiles a little bit. So that's kind of what we'll focus on. I'll take some questions afterwards. And then if we have some time afterwards, we can do some rapid-fire antidotes. Or simply we can just, they're in your handout there. We can go through stuff there as well. Like Steve said, I don't have any disclosures. I don't have any conflicts of interest or have any interest in any pharmaceutical companies or any drugs that I mentioned by name. I will say that in terms of evidence out here, when we talk about any sort of acute phase resuscitation, there's not a lot of evidence-based trials. There's not a lot of RCTs that are double-blinded and placebo-controlled because we're just not capable of doing that in that acute phase early resuscitation situation. That's particularly true when it comes to toxicology and some of the sick toxidromes that we see. So a lot of this is going to rely mostly on the best level of evidence out there. Some of that is RCTs, some of that's consensus statements and expert opinions as well. So I'll try to identify that as well. And when things are simply just personal opinion, I'll identify that as well. So let's start. We'll talk a little bit about opioids, that opioid toxidrome as well, and a little bit about that opioid crisis. We'll go a little bit off topic with this as well. We've come a long way in 100 years since Bayer was marketing heroin over the counter as the sedatives for coughs, and certainly things have changed quite a bit from the certain opioid crisis that we see ourselves in right now. I would say even though there's been some changes through here, I think the biggest change with what we've seen in opioids and what we've seen with opioid toxicity has really happened more in the last 5 years. And I'll go off script a little bit because I want to talk a little bit about some of the history and how we got to this sort of deep, dark hole that we're in right now with opioids and opiate therapy. Anybody know who these people are? I would think you would. This is the Sackler family. The Sackler family is well known as being a significant philanthropists. They have a wing in the Guggenheim Museum. They are well known in New York City, and they are also the private owners of Purdue Pharma, who we know as manufactured and brought OxyContin to market. We'll come back to these guys in a little bit. And just to touch really briefly historically on the opioid crisis and how we got there, there was an interesting presentation and paper by a guy by the name of Dan McCollum, who's a toxicologist, who sort of put forth this model of the 5 Ps of how we got to this current aspect of the opioid crisis. And it's a really nice sort of succinct way to take a look at how bad things have gotten and why they got so bad, from this heroin being just a simple sedative for coughs to this crisis that we're in right now. And the first P that he brings is a medical paper, an article called Porter and Jick. Porter and Jick was a paper that was produced in the 1980 New England Journal of Medicine, and it is still the single most cited resource for opioid safety and opioid efficacy. This was the #1 paper cited when the OxyContin was brought to market. This is still the #1 paper cited for safety and the apparent non-addictive parts of OxyContin as well. I've attached the entire article right here. Actually not an article, it's a single paragraph letter to the editor, but unfortunately this is still what's cited even with the newer long-acting opioids that have been brought to market, like the Opana or extended-acting hydromorphone as well. When we look at the opioid epidemic in 2018, the other thing that we take a look at, or the second P, is when OxyContin was promoted as being not addictive. Part of this was another article, Portner and Foley, which came out in 1986. Dr. Portner published a randomized trial of 36 inpatients, which were given OxyContin, and found only a small amount of these patients actually developed any sort of addiction. This was one of the papers that was used to actually get FDA approval for OxyContin at the time. It should be noted that both Dr. Portney and the investigator in charge of OxyContin approval actually went on to jobs within 2 years with Purdue Pharma. The next P is the development of pain as a 5th vital sign in 2001. This is something that a lot of us that have practiced within the last 10 or 20 years are very familiar with. If you're wondering why every exam room has this pain scale of 0 to 10 and the frowny face to smiley face pain scale, that's because of this pain as a 5th vital sign. Now I could get on my soapbox and talk about a vital sign should really be something that has to be objective, and we don't really have a painometer. But it makes sense that if we're required to ask a patient what their pain scale is and they say 8, they should expect to get something strong for their pain. And really, that's what happened after pain as a 5th vital sign came out in 2001. In fact, we saw opioid prescriptions between 2001 and 2010 in that 9-year period of time go up by a factor of 7. And we saw overdose deaths go up by a factor of 4. I'll say that again. After the administration of pain as a 5th vital sign through JCO and through the FDA, we saw opioid overdose go up 4 times or quadruple. That caused a lot of problems, and in fact, by 2010, we did realize that there was a significant addiction problem because of this. The government intervened, the FDA intervened. One of the big things for that next P was the purging of the pill mills. There's a great article, a book actually, American Pain by John Temple, that takes a look at some of these pill mills in Florida that weren't run by physicians, they were run by businessmen, and you didn't even need to have a physical examination. They were, I think, averaging somewhere between 300 and 500 OxyContin tablets distributed per patient every month with these. And when this happened, there was a tremendous push through the FDA, through the government, through JCO to shut down all these pill mills, to really cut back on the amount of opioid prescriptions that were put forth, which sounds like a good thing. In fact, in 2011, the prescription amount of opioids, which has been increasing significantly every year, peaked. So we've actually seen less prescriptions for opioids since about 2011. The problem is what else started to peak in 2011? What went up for the first time in 2011 after that? For the first time ever, we started to see increases in heroin use. In fact, between 2011 and 2013, we saw a tremendous peak in heroin use going on. In fact, in 2013, about 80%, or 4 out of every 5 heroin users, actually started on pills initially. There's a book, Dreamland, by Sam Quinones, that talks a little bit about this. At the time, a pill of OxyContin on the streets was worth about $20. A bag of black tar heroin was about $5. So we suddenly had a lot of people who never intended to be using opioids as injectable therapy who were now using this when they couldn't get a hold of their pills. So then what happened with fentanyl? Why do we have fentanyl in our heroin, or why are we having a heroin contaminated with fentanyl? It seems strange to say if my breakfast cereal was contaminated with heroin, I would say that's contaminant, but our heroin is now being contaminated with fentanyl, and why is that? This is a tremendous problem. Just in 2013, the CDC recognized that there were 300 what they called recreational or non-medical deaths from fentanyl in 2013. By 2015, that had increased to 1,000 deaths every month. So there's an article or a book that takes a look at this more of a economic perspective called Narconomics by Tom Wainwright, who basically looks at this in the same perspective that Prohibition happened. In Prohibition, when you couldn't have your beer every day, the bootleggers didn't start making cheap, low-quality beer. They made the highest, most potent alcohol concentration moonshine they could because it's easier to run. And that makes sense. It costs about $4,000 to make a kilogram of heroin, and it costs about $4,000 to make a kilogram of fentanyl. However, that same kilogram of heroin is worth about $200,000 on the street. A kilogram of fentanyl is worth about $1.3 million. And because fentanyl is about 50 times more potent than heroin, it only takes a small amount of fentanyl to heighten that perceived potency. That was one of the most catastrophic things because we did have some people who were sort of functional heroin users. They knew exactly how much heroin it took to get them high. There were people who knew exactly how much heroin they needed to take. And now what we've seen is that we've seen fentanyl now almost in the entire heroin stock in the United States. So now we have users who have no idea how much fentanyl they're getting. They have no idea how much opioid they're getting when they're using, and we've seen a tremendous increase in deaths. How bad is it? Right now, opioid overdoses kill more people than car crashes in the United States every year. They kill more people than AIDS and murder combined. Last year, over 30,000 deaths from opioid overdoses alone. About half those were injectable. From a public health perspective, this is fairly devastating. For every single heroin or opioid overdose death, there's 10 treatment admissions. For every single heroin overdose death, there's 32 emergency department visits. There's 130 opioid-dependent users, and we see 825 non-medical or recreational users for every opioid death out there. So we're really stuck in a big issue. So speaking of which, anybody know what happened to Purdue Pharma and the Sacklers for their complicity in this? So they were found to be complicit in the opioid crisis. The FDA did investigate them, found out, of course, when they were marketing OxyContin and their opioids as being non-addictive, they were wrong. There's a lot of, there's an interesting New Yorker article that talks a little bit more about how they manipulated some of the pharmacology, that this really wasn't long-acting. Long story short, they got a big fine. They were fined about $600 million for being complicit in the opioid crisis by the FDA. Out of curiosity, does anybody know how much the Sackler family is worth currently? So they were just listed as Forbes as one of the richest families in the world. Their estimated worth right now is about $14 billion. In fact, that's only going to go up because the FDA has just recently approved the hard-to-say Hysingla, which is extended-release hydrocodone. This, of course, is being marketed as safe and non-addictive, so we're really, really going to be in a big hole to get out of this a little bit. But getting off the soapbox a little bit, how do we treat these things? So how do we treat opiates? How do we treat that opioid toxidrome? Well, we know we see heroin in our illicit narcotics. We talked about that. We've seen this in our opioid analgesics as well. It's important to know that we see opioid toxicity from other things, and we can see this from over-the-counter as well. So dextromethorphan or Robitussin, we'll see this every once in a while with kids locally. They call it robotripping, where they'll take an extended amount of dextromethorphan, and they can get some opioid toxicity from this. If we have infants who ingest Lamodal or Imodium, they can also get toxicity from this. There's been infant deaths from Lamodal and Imodium. That's actually on another lecture. I've done that one pill can kill lecture. It's important to know that Lamodal, dextromethorphan, these are opioid agents. They've been conjugated to larger molecules so they don't cross the blood-brain barrier. However, they still have those side effects of some respiratory depression, cough suppression, and it's also relaxing that or GI tract a little bit as well. And that's exactly what we see with the Toxidrome. We all know this, okay? So we get central nervous system and respiratory depression. CNS and respiratory depression, we get these pinpoint pupils with it, altered mental status. Everything kind of slows down with that opioid toxidrome and opioid toxicity. And what kills people who misuse opioids? About 90% of the time, it's just that. It's respiratory depression and respiratory arrest. We see both accidental and intentional overdoses of this. The remainder of the time, we're starting to see pulmonary edema a little bit more, particularly with some of the synthetic opioids. That's not well understood why. We're starting to see anaphylaxis as well because we have such small amounts of fentanyl in there. There's a lot of other diluents or non-active ingredients that heroin's being cut with, and people are having reactions to those. We see cancer, liver disease. We see all the things related with injection drug abuse, AIDS, and HIV. This is an old slide from 2011, and I left the statistic out here, and I really checked to see if anybody had made this change prior to the fentanyl crisis and prior to the really severe opioid crisis that we've seen in the last 5 years. This study looked at the cumulative risk of dying amongst regular heroin users was about 2% per year. That meant for every year that you used heroin, you had about an increasing 2% cumulative risk. 2% the first year, 4% the second. I can only imagine that's gone up quite a bit here in the last couple of years. We see lots of other things. We see skin and soft tissue infections. The classic thing is this sort of antecubital abscess that we'll see right here. Over on this side, we can see some necrotizing infections as well. Occasionally, we'll see things like botulism toxin for needles, particularly in some of the bigger cities. Some of this, or when people run out of veins to use, a lot of times they'll do this pocketing or skin popping, they call it, or basically subcutaneous injections of heroin as well, which can result in some significant infections and actually occasionally Clostridial infections and botulism as well. How do we reverse it? Probably everybody knows this. So naloxone or Narcan as the agent, which is available. We can give it sub-Q, we can give it IV, we can give it IM. There are these naloxone auto-injectors out, which are not without their controversy, which is probably a little bit beyond the scope of this talk here. But we can reverse it pretty quickly by giving a dose of 0.4 to 2 milligrams up to 4 milligrams IV initially. Most of the toxicologists out there for non-lethal, non-life-threatening overdoses are recommending we start lower, even a factor of 10 lower, 0.04 milligrams per kilogram to start with. And that makes sense because we are precipitating an acute withdrawal crisis in these people. They're not going to die from it, but nobody has ever gotten Narcan and woken up and said thank you. In fact, it's quite the opposite. So if we can bring people up a little bit slower, that helps out quite a bit. So start low, go slow. The other thing that we don't want to slam a bunch of this in is we have a fairly low half-life on this. In fact, the effects of Narcan last about 45 minutes. So if somebody's on something that has an unpredictable half-life, like the agonist-antagonists like buprenorphine, or if they're on a long-acting opioid like methadone and they overdose, that Narcan is going to wear off long before their opioid does. And if you wake them up, piss them off, and they go running away and hide somewhere, they're going to be in a world of hurt. So bringing somebody up slowly is going to be an important thing to do. However, if they are in acute respiratory arrest, if they are blue, you need to intervene aggressively as can, and that would be a good time to give the 2 or 4 milligrams as well. Narcan is a pure opioid antagonist. It works directly on the mu and kappa receptors, predominantly mu kappa receptors in the brain. And it really gives that Lazarus effect if we give it. You know, we see these people go from dead to waking up and angry within a matter of a couple of minutes. So it does work very well in regards to that. So what about these synthetic opioids? We're seeing now for the first time in Iowa in the last couple of years, carfentanil. We're seeing some of the alpha-methyl fentanyls and some of the other things have been created as well. Fentanyl is a fairly easy drug to make, and it's a fairly easy drug to manipulate. Most of the fentanyl that we see in the United States is made in illicit labs in China and in South America. Because it's so potent, small amounts are fairly easy to transport, and there's continuing to be manipulations to fentanyl and the synthetic opioids that we see. As of 2017, fentanyl has been detected in the heroin supply in every state in the United States and in Canada as well. It's been found in Iowa as well, and it's safe to presume that most of the heroin supply in the United States does have some fentanyl in it. Once again, the challenge is nobody knows how much they're getting. We see some of these fentanyl analogs. We know that fentanyl has about a 50 times stronger affinity towards mu receptors as morphine. Carfentanil can be 50 to 500 times stronger. Remifentanil can be even stronger than that. Alpha-methylfentanyl can be also a lot stronger than that. We just don't know what's out there, and that's the biggest challenge. Beyond that are the synthetic opioids that we're seeing out there. The synthetic opioids are generally given a letter followed by a series of about 4 numbers. They're making them so quick that they don't really even have names out there. We did have a death a couple of years ago from the U47700, which is locally known as pink. I don't know if that's a national thing or sometimes known as U4. However, anytime there's that letter followed by numbers and a concern for overdose, that's usually a synthetic opioid as well, and we just don't understand the mechanism of these other than they're incredibly potent in overdose form. The bigger concern with some of the synthetics, the U47700, is they're being found quite frequently now in synthetic pills, or pills that are being marketed as, counterfeit pills that are being marketed as counterfeit Vicodin or counterfeit Percocet. We're starting to see that, and we just don't know the effects. The treatment remains the same. We're still going to give these patients naloxone, but they need lots and lots of naloxone. So this is one of those things, if that initial 0.4 or 4 milligrams doesn't work, we continue to go up to 8 milligrams. I have a colleague in Ohio I talked about who gave 20 milligrams of a Narcan to bring somebody out of a carfentanil overdose. So the treatment remains the same, but we're going to give lots and lots and lots more Narcan if it doesn't work to begin with. Okay, so let's move on a little bit and talk about acetaminophen. A couple people wanted to talk about this, particularly in terms of newer dosing protocols versus the oral dosing protocols, standard and the newer treatment protocols. What's better? Is that 21-hour, 72-hour, 56-hour better? And what's better, PO or IV? So we'll talk about that real quick. Historically, acetaminophen was first developed as paracetamol. That's what it's known as in most of the world. It's been the most widely used analgesic and antipyretic in the world since about the mid-1960s. Toxicity is rare, and it's getting more rare, which is good news. So about somewhere between 150 and 500 deaths reported per year as of 2014. It is still, however, the most common cause of acute acquired liver failure in the United States. It's responsible for about 40% of acute acquired liver failure in the U.S. And untreated or overdose is responsible for about 12% of fatalities. Toxicology-wise, in acute toxicity, we worry somewhere between about 140 and 150 milligrams per kilogram, or about 7 to 10 grams for an acute toxic dose in an adult. Once we get the chronic or super therapeutic toxicity, or in particular when we talk about these sort of subacute ingestions where somebody took a handful of Tylenol and then an hour later they took another handful of Tylenol, things get a little bit more tricky, but we'll touch on that here in a bit. Pathophysiology, Tylenol itself. Tylenol is one of those compounds, and there's a lot out there that by itself is not toxic. Our body actually makes it toxic, which is an important thing to know. About 90% of acetaminophen is conjugated and excreted by normal pathways, and we have no problem. However, there is a small amount that is metabolized through that cytochrome P450 system in the liver and goes through that central lobular region of the liver where we see that direct toxicity. And that toxic metabolite is something called N-acetyl-parabenzoquinonamine, or NAPQ. And NAPQ is the toxic thing that we worry about and is actually produced by our body. NAPQ has direct toxicity to the liver and direct toxicity to the hepatocytes, but the good news is we have our own antioxidant in there, and we have a reductase molecule, glutathione, that is able to detoxify NAPQ. The problem is we only have a finite amount of glutathione stores in the liver itself. And we'll talk about a little bit how we can use that for acetaminophen toxicity itself. But once again, in overdose, we have acetaminophen, largely non-toxic. About most of this pathway goes through hepatic sulfation, glucuronidation. There is a small amount that goes through that cytochrome P450 system. About 70% of that small amount that does go through the P450 system is metabolized to mercapturic acid, which is a safe compound. However, in the interim, we have that NAPQ there, and that's the bad agent. And if we can't We run out of glutathione, that's when we run into cell death. That makes sense when we take a look at actually the stages of toxicity too. And there's 4 stages of toxicity for acetaminophen. And this is one of the reasons it's a really bad actor, because when we have that first stage, that sort of first stage to that first day or first 24 hours of toxicity with acetaminophen, people really aren't that sick, and they generally have that sort of flu-like presentation. They don't feel good, they get a little nausea, some anorexia, some malaise. Some of them don't have any symptoms at all. Most people don't feel that bad. If you do check LFTs, you might start to see some subclinical elevations of their LFTs later on, towards the end of that 24-hour period of stage 1. But for the most part, they don't do that bad. And the scary phase, which happens between day 2 and 3 or 4, that 24 to 72-hour period, is at stage 2, which is the quiescent phase. And that's where people start to feel better. So they felt kind of crummy at first, and then they start to feel better. But it's unfortunately during that quiescent phase that we start to see the real severe toxicity take place. That's when we start to see really marked elevations of our LFTs, and that's when we start to see liver failure start to happen, which brings us after about day 3, or about 72 hours in, to the most critical phase when we have people start to develop signs of liver failure. And it'll have everything you'd expect with acute liver failure. Jaundice, hypoglycemia, bleeding. They could be encephalopathic with this. They get renal failure and cardiomyopathy. We do those biopsies. We'll see that classic presentation of central lobular necrosis and those hepatocytes. And about 4% of patients who do develop this degree of hepatotoxicity will go on to fulminant liver failure. If they make it through stage 3, they go on to stage 4, which is that regenerative phase. And that can be anywhere from about 1 week to 3 weeks on, where they will either die from the complications in stage 3, or they actually get some regeneration and get better. Periodically, I've talked a little bit about pediatric overdoses and things we worry about in kids, and kids can get smaller doses of medications and get a little bit sicker. But here, who's least common to have a fatality from acute liver failure in an acute acetaminophen overdose? Is it adults, kids, or adolescents? Anybody have any guesses? Nobody wants to say it's kids. That's exactly right. So in fact, there was a pretty good Cochrane review that looked at acetaminophen overdoses and kids, and under the age of 6, there's not been a reported death from an acute acetaminophen overdose in anybody under the age of 6. Now, there's been overdoses and deaths from chronic and supratherapeutic toxicity, but under the age of 6, kids do pretty well, and that's thought to maybe be postulated by the mass of the liver to the mass of the kid. Since kids generally have a bigger per body weight percentage of liver tissue, they may be able to detoxify a little bit more. So here's that classic both gross and histopathologic presentation of acute liver failure from acetaminophen. And we can talk a little bit about laboratory evaluation as well. We're going to talk about the Rumack-Matthews nomogram, which is how we can measure acetaminophen toxicity. The nice thing about acetaminophen is that even in overdose, it tends to follow first-order kinetics. So there's very few drugs, even when we take them in mass amounts, will continue to follow the normal metabolism. Acetaminophen seems to do that in acute overdose, so we can use that nomogram. There's been nomograms for other things like salicylates, which haven't worked pretty well, but the Rumack-Matthews nomogram, which we'll talk about, works pretty well, and we just plot the concentration of acetaminophen in the body over time. It's been fairly well validated in the literature. We usually start that nomogram at about 4 hours because that's the half-life of acetaminophen, and we can only use this nomogram for an acute acetaminophen ingestion of a non-extended preparation acetaminophen. If they have an extended prep acetaminophen, the manufacturers will recommend an additional 8-hour level, but that's more of a recommendation that's never been validated. So here's the Rumack-Matthews nomogram right here, so you can see that this is just the concentration of acetaminophen on micrograms per milliliter, which we use here, which is sort of just plotted over time. We can only start this at 4 hours. That's important. So if you measure a non-lethal Tylenol level at hour 1 or hour 2 or after ingestion, that doesn't count for anything. We need a 4-hour post-ingestion level, unless their initial level is 0. At that point, you don't need to move forward, although our Iowa Poison Control Center would still recommend a 4-hour level, even if it's 0. Most resources will say if they have an initial undetectable acetaminophen level, you can stop there. However, if they do have even a minimally detectable acetaminophen level in overdose, we need to get that 4-hour post-ingestion level. And this has been validated out to about 20 hours. So that way we can say if we know that they present 8 hours after their ingestion, and we know that their level is, let's say, 130 micrograms per milliliter, we can see that we'll be sitting right in that hepatotoxic line, and we want to start treatment there. The red line suggests hepatic toxicity. In the European literature, they don't have this bottom half. They just use 150 milligrams per kilogram as a toxic. U.S. literature, they go a little bit lower. What else do we see with laboratory evaluation? Well, we do definitely want initial LFTs because that's going to establish our baseline and acute injury. However, we'll see significant elevation in our LFTs with acute liver injury from Tylenol. In fact, this is probably where we'll see the highest level of our LFTs going up to 10s to 60s to 100,000 in overdose. And we can see that in that 2 to 3 day period out afterwards where we have LFTs measuring in that 50, 60,000 range. It's very diagnostic for acetaminophen overdose. It's, however, not very prognostic, meaning if we see those LFTs that high, it does likely mean that they've had an acetaminophen ingestion and they're toxic. However, it's not prognostic. The average level of an AST in patients who die peaks at about 3,000. We'll see an anion-gap metabolic acidosis with this. We like to check our ABGs. And we want to follow our Ts, our PT as well. If we have a rising PT in the setting of falling transaminases, that portends a very grave prognosis. The same thing for an elevated total bilirubin. That makes sense because that's suggesting that liver failure has already occurred. So we always do a toxicology screen for co-ingestions as well. So in patients that make it through that stage 3, what's the incidence of permanent liver damage in people who survive acute liver injury from a Tylenol overdose? Anybody have any suggestions out there? The answer is actually 1. So it's almost non-existent. If people can make it through that acute phase or that acute toxicity initially, they generally do pretty well, and there's enough hepatic regeneration that we can see there that mostly if people can make it through acute liver failure, in otherwise healthy patients, the progression to a chronic liver disease is pretty low. So how do we treat this? Well, we treat this with N-acetylcysteine, which is Mucomist, or more recently marketed by Cumberland Pharma as Acetadote. So what does N-acetylcysteine do? Well, the easiest way to think about it is it's glutathione. Remember, our glutathione detoxifies our NAPK. The NAPK is what causes the injury to the hepatocytes as well. Once we use up that glutathione, which happens after about 8 hours post-ingest, we use it up, then that's when we start to have that liver injury that occurs. So if we can give this within about 8 hours of overdose, we do pretty well. The effect or the success rate decreases each hour after an acute overdose. However, most toxicologists and hepatologists will recommend giving this all the way up to transplant or death, even if we find out about it later. Once again, this sort of acts as glutathione. So as we use up our own glutathione stores, N-acetylcysteine works the same way to help reduce or detoxify, or acts to get detoxify that NAPK quicker. It's a really good medication, works pretty well, and it's fairly safe. It is safe in pregnancy. It's recommended to be given IV in pregnancy, however, not oral. So what about treatment regimens? Well, we have 3. It's important to know they're all about the same. The N-acetylcysteine that we used to give used to be an oral dose. We used to give about 140 to 150 milligrams per kilogram. Loading dose is always about 150 milligrams per kilogram. That's nice and easy to remember. That's the same as the toxic dose of acetaminophen, which is kind of nice. We used to give this as an oral loading dose, followed by about 70 milligrams per kilogram every 4 hours for 17 doses. Used to be the 3-day protocol for this. The 20, that's actually 21-hour dosing regimen, is 150 milligrams per kilogram as a loading dose over that first hour, followed by 50 milligrams per kilogram over 4 hours, and then 100 milligrams per kilogram over 16 hours. They're all about the same. They've all had the same efficacy. The N-acetylcysteine that's marketed by Cumberland Pharmaceutical is nothing different than the N-acetylcysteine that we have normally, or the Mucomist. The big difference, and the reason they have the patent on it, is they came up with the new dosing regimen. There's no difference between oral and IV formulation. The IV formulation is much more expensive, and the IV formulation does have some risk of anaphylaxis, but mostly we can tune that down by turning it down a little bit. The biggest problem with the oral formulation is if you've ever smelled mucomist, it's hideous. It's awful to smell, and there's a tremendous risk with nausea and vomiting or people who are just unwilling to drink it. I would say in the last 5 years, I don't think I've ever given oral mucomist here. I think we've given this almost exclusively IV. Oops, I went back here a little bit. Let's see if I can fix that. All right, so if we do give oral and we give charcoal, the effects of activated charcoal do not hinder the administration of PO and acetylcysteine. That's kind of important to know if we're going to give that and we have an acute ingestion. We're going to give charcoal within that first hour of a patient who is awake. The amount that the activated charcoal absorbs in mucomist does not affect the treatment. Okay, so you can still give charcoal, you can still give mucomist, they'll be able to treat as well. And what about chronic overdose? It's another kind of important thing to talk about as well. And this is where it gets a little bit more tricky. If we have a chronic overdose, if we have a subacute overdose, meaning somebody didn't take the Tylenol all at once, they took a few pills and another few pills, and an hour later they took another handful, things get a little bit trickier because we can't use that Rumack-Matthews nomogram for toxicity. Most toxicologists will recommend a conservative treatment approach. That's important. Patients are at risk if they've had more than 7 to 10 grams chronically, or 4 grams if they have risk factors. And what are those risk factors? If they've had gastric bypass surgery, if they're malnourished, if they're alcoholics, if they have any sort of other medications that are also metabolized by that P450 system, then we want to be even more conservative if possible. We want to initiate therapy if anybody has abnormal LFTs, liver tenderness, jaundice, and ill appearing. If we don't know the amount that they took, but we're assuming chronic ingestion, and we want to continue that N-acetylcysteine until the LFTs normalize, we find another reason for the LFTs to be elevated, or the patient expires. So once again, when do we initiate our N-acetylcysteine? Liver tenderness, jaundice, elevated LFTs. If we have a detectable concentration of 20 micrograms per milliliter with or without LFT elevations in a patient who is sick otherwise, we should initiate that. Or if they've had chronic ingestion with LFTs and they appear sick, we should initiate them on N-acetylcysteine until we have improvement in their LFTs or they get better. Another thing that's important is, what if we have those elevated LFTs and we have a suggestion of acute liver failure, but the patient has not demonstrated or told us there's any sign of overdose? The current recommendations are for any acute undifferentiated liver failure that N-acetylcysteine be started until another cause is found. And that makes sense because remember, this is still the most common cause of acute liver failure in the United States, about 40%. And so the risk is high enough that there could be acetaminophen ingestion there that this is recommended to be started. Indications for transplant, we'll just kind of pass that by really quick. Anybody who's really, really sick, anybody who's expected not to survive, there are calculators out there. You can use MELD score, you can use King's criteria. If they are acutely encephalopathic, if they demonstrate evidence of hepatorenal failure, then it's a suggestion they should be managed in a transplant center. All right, so that's acetaminophen. So we've had a couple of antifreeze overdoses here. And so somebody mentioned that I should talk a little bit about that as well. I'm not a baseball card fan, but I'm a big baseball fan. However, I saw this card and I had to have this ETOH guy for sure. All right, so let's talk about toxic alcohols. We've talked on and off about peds and stuff like this. This is one of those things where we really, really worry about pediatric ingestion. A single swallow in a kid is lethal, okay? And that's important to know, okay? About a teaspoon of ethylene glycol to a pediatric patient is lethal. The lethal dose is under 1 milliliters per kilogram. So it doesn't take much for kids to get really, really sick from this. That makes sense. I mean, right here we've got some red grape juice on the right. This Boost juice is a red-colored ethylene glycol. I mean, they both look pretty appetizing to me. The challenge with ethylene glycol, too, is it's very sweet tasting. It's very sugary. So kids will drink it. Animals, dogs and cats will drink it as well. So it's one of those things that we do worry about quite a bit. I guess I've been told every presentation has to have a really busy slide with lots and lots of stuff on that nobody understands. So here it is, but it's actually kind of an important slide because it tells us one thing. Once again, ethylene, methanol, ethylene glycol, isopropyl alcohol by themselves are not toxic. It's that darn metabolite. So our body actually makes these compounds toxic. And the bad actor here is the enzyme that does that, which is alcohol dehydrogenase, right up here, okay, which works against all these compounds. So if we have regular ethanol, our alcohol dehydrogenase works to turn that into acetaldehyde. What does acetaldehyde do? We're going to see a lot of it this weekend. It's what gives you that killer hangover, okay? So the hangover is from the acetaldehyde as well. For methanol, that ADH works to turn methanol into formaldehyde and then subsequently formic acid, which is the toxic metabolite that we worry about. And similarly, for ethylene glycol or antifreeze, the glycolaldehyde and glycolic acid, which is produced by alcohol dehydrogenase as well, and subsequently aldehyde dehydrogenase, which are two enzymes that take these chemicals, these ethylene glycol, and actually make them into toxic problems. How does that happen with methanol? Methanol is our wood alcohol. It's metabolized to formic acid. Formic acid is directly toxic to the optic nerve and the basal ganglia of the brain. We'll see a metabolic acidosis with this. We'll see all these sort of sedative, hypnotic things we'd see with regular alcohol as well. However, with that, we do get some cardiotoxicity. We can get methemoglobinemia. We can get a Parkinson's type presentation as well, because this is toxic to the basal ganglia. This is directly toxic to the optic nerve. People will complain of this snowstorm loss of vision and blindness from this as well. This is an irreversible blindness, and it's an irreversible Parkinsonism because this is direct toxicity that kills those neurons. With methanol, we'll see an elevated anion gap acidosis. We'll see an elevated osmolar gap, and you'll see an elevated osmolar gap in any alcohol. These are big molecules. So you'll see an elevated osmolar gap with this. With methanol and ethylene glycol, you'll also see that elevated anion gap as well. So remember your mud piles, it fits right in there as well. Ethylene glycol, once again, it really doesn't take much to make anybody really, really sick from this. Ethylene glycol is metabolized to glycolic acid and calcium oxalate. These are really, really bad actors here. Our toxicity, our cardiotoxicity through glycolate, and also cardiac and renal toxicity through oxalic acid. Oxalic acid precipitates these formations of these crystals, these oxalic acid crystals, which block the renal tubules. So we get this direct renal toxicity with this as well. That also binds up a ton of calcium. So these patients get hypocalcemic and they get arrhythmias from the hypocalcemia as well. We get methemoglobinemia with this as well. We get a lot of cardiovascular damage and dysrhythmias from this as well. They get an anion gap acidosis from this as well. They get an osmolar gap. By the way, anecdotally, the anion gap acidosis that we see with ethylene glycol toxicity has always been the most severe that I've seen. And in fact, with ethylene glycol toxicity, the pHs that I've seen are the lowest that I've ever seen in somebody who's still alive. We'll see pHs of 6.6, 6.7, incredibly low stuff. And if I'm seeing an ABG or a pH that low, I'm almost going to presume that this has got to be ethylene glycol and treat this presumptively. Once again, they'll also have an elevated osmolar gap with this. So how do we treat these? Well, we treat this with Fomepazole, which is a competitive inhibitor of that enzyme that we talked about earlier. It works right against alcohol dehydrogenase. So what does it do? It keeps those compounds in their parent form. So basically, Fomepazole binds with about 100 times affinity to that enzyme, and so we keep these compounds in their parent form. Our ethylene glycol can be either metabolized out through alternative pathways in the body or more commonly dialyzed out as well. It's given as a dose of about 50 milligrams per kilogram as a loading dose, and it's a minimally toxic agent. It's a really neat drug that works very, very well and will save lives. Prior to Fomepazole, or about 20 years ago, we used to have to get these people drunk. So regular alcohol actually has a higher affinity for ADH than does methanol and ethylene glycol. So if we can keep somebody drunk or keep their blood alcohol concentration at about 100 milligrams per deciliter, we can actually treat them as well. So this is an older but still interesting way to treat higher alcohols as well. So how do we load this? Well, there's IV alcohol loading that we can do. Most commonly, if this is done or If you're in a foreign country and need to do this or something like that, there are formulas on how you can do this. You can take the proof of the vodka or whatever you buy from the liquor store, and you can basically put this in this formula to figure out how many grams of alcohol are in that particular substance, and then you can calculate. They need about 0.6 to 0.8 grams per kilogram maintenance dosing, and that'll keep them right at that level of about 100 milligrams per deciliter per hour. This is kind of tricky in kids who get hypoglycemic at the drop of a hat with alcohol, but an option. Touch briefly on isopropyl alcohol, rubbing alcohol. So sedative hypnotic, it's more potent than ethanol, so smaller amounts will get you drunker. It's metabolized to acetone. So if you're one of those people that can smell acetone on your DKA patient's breaths, you may be able to smell it on their breath as well. They don't get an acidosis with this. So acetone, the keto acids that we see in DKA are beta-hydroxybutyrate, but acetone itself is not an acid, so we won't see a metabolic acidosis with this, but we will see that markedly elevated osmolar gap. So if somebody comes in and they look drunk, their ethanol level is 0, but you're sure they're drunk, you can check a gap, and if they have a wide osmolar gap, very likely they've ingested rubbing alcohol or isopropyl alcohol as well. Isopropyl alcohol, by the way, does not need to be treated with Fomepazole. It's just treated just like you would with ethylene glycol, just symptomatically. All right, so how much time do I have left here? I get till 10 after. Okay, so we'll kind of do some rapid fire antidotes real quickly here, and then I'll stop here and take some questions or whatever. We'll go from there. So initially we want to talk about antidotes, and I did want to just kind of do some rapid fire antidotes as well. So here's an EKG. A girl came in about 3 or 4 years ago, 14-year-old girl after suicide attempt. This is her EKG. What'd you take? Oh, you got it. I heard it. Tricyclics. So the real classic presentation for TCA overdose EKG, a wide complex tachycardia that we see. TCAs are really making a resurgence. We're starting to see in the toxicology literature TCA overdoses go up. We're looking for alternative ways to treat pain. And so that's one of the things that we're seeing. We're seeing an increase in salicylate toxicity, topical salicylate toxicity, and tricyclic toxicity. It's very common as a suicidal agent. So fatalities as low as 150 milligram tablets in kids. We see in it's very small kids, and our effects we see coma and severe cardiotoxicity. We used to think in the toxicology world that this was all antimuscarinic toxicity, but it's not. Our toxic effects are all from that sodium channel blockade in the heart. So how do we treat this? Treat it with bicarb, okay? And lots of bicarb. We're going to start with about 3 amps IV if we have a concern. And this is one of those times where you don't go slow and give a little bit. This is where you can take those 3 amps or about 150 milligrams of bicarb and you really white knuckle it in. You can watch that wide complex tachycardia in the monitor actually close before your eyes, and it will save lives. Bicarb works by 2 mechanisms. So it both works because the TCAs themselves are acidotic, and so we create this little more alkalotic environment, which helps affect heart function, but it's really that massive sodium load that we get with sodium bicarbonate that helps quite a bit to help flood those blocked sodium channels. So once again, that's the classic EKG presentation. And this is really the classic finding here is we see this terminal R in lead AVR. And that's just a pathognomonic finding for TCA overdose. I think it's the only time in medicine that you use lead AVR unless you're looking for like in a small occult LAG infarct. So a couple of things. I was like this picture by Frank Netter. He always does such a good job of making these kids look so sick. We generally do not do much inducing vomiting, giving Ipecac, or do any gastric lavage anymore. You know, I keep bringing up this pediatric thing. This is a slide from another presentation that I do, but I like it. So here we've got a calcium channel blocker. We've got a TCA. We've got some clonidine, all things that can kill kids, and we've got some Skittles. And I don't know about you, but they all look pretty appetizing to me. All right. So let's touch real quick, and we'll kind of finish after this. We'll do beta blockers and calcium channel blockers because those are the things we also see that can cause some really scary overdoses as well. Really high lethality, particularly for our calcium channel blockers. And the toxic effect is just what the drug should do, only it's a lot worse. So we see bradycardia. We see hypotension, right? The drug effects are getting much, much worse. The sustained release preparations can have delayed toxicity, and we'd expect to see what we see, cardiovascular collapse and circular collapse with these as well. What's the antidote for beta blockers? Glucagon, that's right. So it's not just for esophageal fluid impactions anymore. So we give this quite a bit, 5 to 10 milligrams IV. This works really, really nicely. And it works by actually opening up sort of a back door behind those beta receptors that are blocked. So it goes through that cyclic AMP metabolism and bypasses those beta receptors. So if we give glucagon, we're going to give a lot, but it generally works with both improving blood pressure, heart rate, and cognition. If we want to give it slow, I will pre-treat with some sort of an antiemetic because glucagon makes people throw up quite a bit, and we're given a fairly high dose of this, so we want to watch for nausea and vomiting. Calcium channel blockers are the really bad one. Single-dose tablets of verapamil and nifedamine in kids can be fatal, and this affects the cardiac and arterial vasculature. The problem is this affects all the things that our vasopressors affect. So the normal things that we'd like to give, our norepinephrine and our epinephrine and our phenylephrine, the normal things that we would give for a hypotensive patient don't work really well here. So these people can get really, really sick, and you can have them on massive doses of Levophed, but because those receptors are blocked, they don't do really well. And patients who have calcium channel blocker overdoses do very poorly. There's a lot of high lethality out there. There are some new treatment algorithms out there, however, which have been shown to work pretty well. Calcium makes sense. It doesn't work as well in practice as it should intuitively. It makes sense, but it does affect the hypotension to some degree, so we can give them calcium. The sooner we give it, the better, but we really need to push those serum elevate levels up above 10, so we got to get them up pretty high, and we always run a risk of some cardiovascular side effects of that as well. So calcium is one option that we can give for calcium channel blockers as well. We can give glucagon as well, the same mechanism, but unfortunately, that doesn't seem to work very well. We try our vasopressors, but they don't work very well. So what has been shown to work? Well, a couple of the newest things out there that have worked really well is Hyperinsulinemia-Euglycemia Therapy. And this is a really neat thing out there that's not been studied in any sort of randomized fashion, but is now recommended out there because there's enough case studies and enough literature reports. And what is this? We give them high-dose insulin. These are not our diabetics. We're giving them a unit per kilogram. How much? A unit per kilogram. And that's not ideal body weight. That's what we give them. And we're going to push this through. We give them as much D50 as they need afterwards. We follow their potassium with this as well. But this has been shown and actually has been bumped up in a lot of reference textbooks as being now close to first-line treatment for calcium channel blocker overdoses. How does it work? Well, our heart normally lives on free fatty acids, so what we're doing is we're increasing our myocardial contractility by increasing glucose consumption and carbohydrate consumption, so we're really trying to change that heart metabolism over a little bit more. So high-dose insulin therapy has been really well studied. It looks really good. Another alternative there is intralipid therapy as well. Intralipid therapy used to just be given for local anesthetic toxicity, but it seems to work well for any sort of lipophilic ingestion and potentially for other cardiac medications as well. This basically acts as a shuttle or acts as a lipid sink. So not only does it bind up a lot of the toxic molecule that's there, but it acts as a shuttle from the vital organs that are affected and actually can help bind those as well. Dosing's right there, and it does seem to work very well with not a lot of side effects. That's a lot to take in, and it's sort of confusing. If it makes you feel like you're going to want to jump off a bridge, our Iowa Poison Control Center does have guidelines for high-dose insulin therapy for overdose. Those are their guidelines there. They also have recommendations for intralipid therapy as well. So we have options for there as well. So there's the number you need to call, and they'll be able to guide you through this. Our Iowa Poison Control Center, our toxicology are really good. And they have a lot of the more advanced stuff out there as well. Touch real quick on methyl salicylate. We'll go from there. So once again, we're seeing lots more topical agents. As we're doing our best to use less opioids, we're using other things. There's a lot of other over-the-counter preps as well. Methyl salicylate is oil of wintergreen. Contains a tremendous amount of aspirin. Okay, so a teaspoon contains about 7,000 milligrams of aspirin. So a teaspoon of oil of wintergreen contains about 90 baby aspirin, 4 times the lethal dose of a 10-kilogram child. There was recently a death in New York City from a young hurdler who was smearing this all over her legs and ended up with salicylism and toxicity. So it's not an uncommon thing there. We treat this the same way we treat aspirin toxicity with alkalizing the serum and urine. Let's kind of stop here. I'm going to take some questions here, and then we can move on to other stuff like that. Job security is what that slide is. All right. Anybody have any questions, or otherwise we can kind of let you guys go, or if there's any other questions, any other antidotes in the handout, I can take those quick too.
This is not exactly a question. I just want to remind everybody that if people are anaphylaxing for whatever reason in the setting of a beta blocker, glucagon is also the drug of choice. And I wanted to ask about the dosing because, my books say 1 to 4 milligrams. That seems dainty compared with what you're using. Am I right?
Yeah, that's exactly right. So that's a good point. So glucagon can be used in the setting of treatment. So it's a good point. If somebody has an anaphylactic reaction and they're already on a beta blocker, they might not do as well. That epi might not affect them, and that epi is that first-line treatment for anaphylaxis, so they may need pre-treatment with glucagon. So I would say probably 1 to 4 milligrams would be what I'd use to sort of pre-treat them if they weren't toxic. The glucagon, 5 to 10 milligrams we're using for acute toxicity. If they were on a beta blocker and had beasting anaphylaxis or something like that, I think it'd be okay giving the 4 milligrams. Would be just fine, because you just want to just open up those channels a little bit more to that epi. So yeah. Anything else? All right, guys, cool. Thanks so much. If you have any other particular questions or some of the other stuff I didn't get to, just come down and grab me. I'll be here for a little bit.